This is part 2 of the movement dysfunction lectures, and in this lecture we're going to look at the characteristics of cerebral palsy, specifically focusing on the neuromuscular system. But in addition to that, we're going to look at all of the contributions to movement impairment from other systems. And then we're going to look at some pictures of children and try to recognize atypical development through observation. So this slide just shows the range of severity that children have with cerebral palsy, and it goes from mild, moderate to severe. And you can see the picture of the little girl on the left most likely has left-sided hemiplegia. You can see the fisting that the child has on the drumsticks with her left hand, and her right hand is more relaxed and open. Postural control to sit, and most likely is ambulatory, moving around her environment. The middle picture shows a little boy who's got spastic diplegia, and in this severity is more moderate. He's ambulatory, can move about his environment, but with the assistance of an adaptive equipment. This is a rollator walker. It's a posture walker that goes behind him to help him stand more upright. And the third little guy is in a wheelchair. You can see that he has a little butterfly harness type thing, but because he doesn't have good postural control to hold himself up. His mouth is open. You can see the tone in his upper extremity. So this little guy would be classified as severely involved. Besides the severity, we also look at the type of CP, and the types correlate with the centers of the brain that we talked about in the first lecture. So the first one is stiff muscles, and remember this was the cortical and subcortical areas of the brain are damaged in the motor cortex. These children are going to have hypertonicity in their extremities. They're usually patterns. The upper extremity tends to be more in a flexor synergy pattern, and the lower extremity tends to be an extensor synergy pattern. The children are going to have limited or loss of volitional movement, and their movements are, especially in the more severe children, are going to be controlled by primitive postural reflexes such as the ATNR, the STNR, the Moro. Remember, this is the most pronounced, this is the highest percentage of kids we're going to fall under this category. The next is dyskinesis, or uncontrollable movements, and this is our children who have athetosis. Their movements are slow, writhing, sinuous, aimless, and there may be a fluctuation of tone from low to normal. Usually with pure athetosis, there's very little spasticity, and there's not going to be much coactivation of the flexor and extensor muscles. Many times you will see the spasticity in the mixed type of cerebral palsy. Their tone may fluctuate from being very low and floppy to severely stiff. And then another area that we looked at was the part of the brain that was affected was primarily the cerebellum, and these are our kids who have ataxia. They have very poor balance, very poor coordination, and many times the postural tone is low proximally. These children are very easily fatigued. The distribution of involvement is directly related to the amount and area of the brain that has been damaged. Monoplegia just means the involvement is in one extremity. Diplegia means that the involvement is primarily in the lower extremities. Doesn't mean you can't have some involvement in the upper extremity. The middle picture shows representation of diplegia. So you have increased tone in the lower extremities and to a lesser degree in the upper extremities. Quadriplegia, you're going to have involvement in all four extremities. The tone is going to be higher in the upper extremity, or the involvement more so in the upper extremity than the lower extremities. With quadriplegia, the amount of damage is, or the severity of the damage is pretty equally distributed in all four extremities. There is another term that sometimes therapists will use that further characterize what's going on, and it's called bilateral hemiplegia. The bilateral hemiplegia definition describes the distribution. The damage is probably more severe on one side than the others. That would help you to determine, like, the right side is more involved than the left side, And bilateral hemiplegia is probably a more accurate way to explain that than just saying quadriplegia. And hemiplegia is just involvement on one side. You can see in the picture the upper extremity flexor synergy pattern. Synergy pattern tends to be one of flexion, and the synergy pattern in the lower extremity tends to be one of extension. Now we're going to look closely at the primary neuromuscular system impairments. And these encompass a diverse group of problems that represent major constraints on movement and postures. Positive signs are present but shouldn't be present in normal development, whereas a negative sign is an absence or a reduction in skills that should be present. We're going to talk about each one of these signs in a little bit of detail. But before we get started, I wanted to take a little bit of time talking about normal muscle tone, because I think you have to understand, in order to understand abnormal tone, you have to have a basis from where to start. Normal tone varies from one individual to another. Within the range that is considered normal, the degree of normal tone depends on such factors as age, gender, and occupation. Normal tone is characterized by the following. You want to have effective coactivation in order to have stability. Say if you're sitting upright, your flexor muscles and your extensor muscles of your trunk need to be working together for you to maintain your stability. However, if you went to move, you'd have to have an ease or ability to shift from stability. So you're bending over to pick something up, your flexor muscles of your trunk are going to be more active. You want a gradual balance between the two muscles groups. There is some controversy surrounding the differences between spasticity and hypertonicity, but the concept itself is hard. Tone itself is a hard concept to really understand until you feel it, and we will do that when you come to the ARC. So I'm going to group the terms together. Technically there is a difference between, so just that you know that. So we're going to look at it in whole, and it describes many abnormal behaviors often seen in patients with a neurological disorder. We already talked about that this is in the cortical and subcortical areas of the brain. That's where the damage has occurred. And the two components are the dynamic and the static component. The dynamic is the resistance offered by the muscle as it is passively elongated and is caused by both a neural, which would be the tonic stretch reflex, and non-neuronal, which would be the biomechanical factors such as what's occurring in the muscle spindle. And then you have the static component, which the tendency of a muscle to return from a lengthened position to a normal resting position and is caused by the non-neuronal factors. Spasticity is characterized by hyperactive stretch reflexes, the clasp knife phenomenon, and clonus. In a spastic muscle, there is a range of free movement and then a strong contraction of the muscle in response to stretch, and then free movement, then a strong contraction of the muscle when the muscle suddenly relaxes. Let's take a look at this picture. Now we're not going to be able to see everything because we can't see movement, but when you look at this little guy, he's about 3.5, and he did have a hyperactive stretch reflex. So when you stretched him, he did have that clasp knife kind of phenomenon. You can see that his tone is high, and let's look at the synergy pattern. In the lower extremities, he has much in their high tone in extension pattern. You can see the hip extension, knee extension, and plantar flexion at the ankle. As opposed to the upper extremities, they're doing two different things. There's more tone in the right and in that flexor component. You can see that with his arm tucked underneath his trunk. If I had to classify this child, the classifications of cerebral palsy, I would say he is the level of severity is more in the moderate to severe range. His distribution is more in the lower extremities than the upper extremities, so that would be spastic diplegia. But as you can see, there is involvement in the upper extremity. He has excessive coactivation of the antagonist muscles. This is why he can't move. His muscles are very stiff. So his extensor muscles and his flexor muscles are activating at the same time, which keeps him in a static position. Associated movement, you have an overflow. We do this sometimes in normal when we're stressed or when we're first learning an activity. We might, like in threading a needle, we might hold our mouth a little bit funny. That wouldn't necessarily be an abnormality, but it's except when it's excessive, and you see it every time with children with CP. It's called an associated reaction. This child also had clonus of his lower extremity, so he'd have his foot would rapidly fire. Another sign of this of spasticity. Okay, so now we're going to switch gears and we're going to talk about hypotonicity. Is low tone. Children who are low tone are going to be very slow to respond. They tend to sink into gravity. Their joints, because they have a lot of flexibility, there's no stiffness there at all. So their joints are very mobile, or what we call hypermobile, as opposed to the child who was hypertonicity. Their joints are very stiff, and they would be considered hypomobile. There's no move. So we'd look at this little girl. She's the type of sitting that she's sitting is W sitting, although you can only see one side. So she's, if you looked at her, her legs look like they're in a W position. They're internally rotated at the hip. She has a wide base of support because she doesn't have adequate postural control in her trunk to hold her upright. You can see a little bit of protruding belly. Upper arms, I mean, they're in fairly good position. And her head and neck, so I would classify her as mildly involved with hypotonia. Many times with kids who are low tone, they will, because of the position that she's sitting in, with the internal rotation, the hip alignment, the tendons will lengthen on the extensor side and shorten on the flexor side. Her pelvis will go into an anterior pelvic tilt. We're going to see her again in another picture and standing here in a minute. And this is a compensatory strategy that she's using to biomechanically kind of hang on her joints to help support her. Can get her into problems later on because she actually has, even though her joints are very hypermobile, they are compensatory strategies that she's using to support herself are causing some contractions at those joints. Another characteristic of children with cerebral palsy is that they have impaired muscle activation. They'll have excessive co-activation, and this is the simultaneous activation of the agonist and antagonist muscle groups across the same joint and acting in the same plane of movement. So this little girl, as she's reaching, she really doesn't have any, elbow is an extension. You've got a little bit of flexion in her left, but there isn't really a graded, controlled movement in her reach because her arms are stiff and their joints, because of this, biceps and triceps are activating at the same time. So her movements are very stiff and controlled, which causes her to get tired a lot easier, or the muscles, because the muscles fatigue because they're constantly firing. Typical development, the muscle as she's reaching, extensor muscles would be the agonist, your triceps, and your flexor muscles should be relaxing, but with hers there's a constant force. And this leads to synergy patterns that we see in children. Children who have mild to more moderate cerebral palsy are going to have difficulty with impaired motor execution. Impaired modulation has, the child can't produce the appropriate amount of force and tension that they need for accuracy. So when a child goes to reach for an object, they may overshoot it or undershoot it. Or when they're standing up to walk, they have difficulty accelerating and decelerating. So they might walk, but then they have to go up against a wall to stop, or a piece of furniture because they can't decelerate. Their timing and sequencing is going to be coordination issues. They're going to be very slow in their performance because they have problems stopping the muscle contraction. And their reaction time is also going to be much slower. Excessive overflow is that associated reactions that I was talking about earlier. In normal controlled systems, this is when you have the tongue or the mouth posturing when threading a needle. Okay, in CNS pathology, however, overflow contractions can inhibit the normal reciprocal relations between agonists and antagonists, which prevents coordination. This inability to produce isolated muscle control when exerting effort can make it impossible for the child to move the muscles around one joint with moving the muscles of the entire extremity. Another problem that can occur is muscle weakness. And a common error to confuse high tone with strength and low tone with weakness. Weakness is the inability to generate sufficient levels of force in a muscle for purposes of posture and movement. It is a primary neuromuscular impairment in persons with upper motor neuron lesions. The secondary impairment that occurs when the muscle is weak over a period of time, you get varying degrees of atrophy and hypertrophy can occur. So that would be one sign that you might look for to determine. There is a surgical procedure that is done with children primarily with spastic diplegia. It's called selective posterior dorsal rhizotomy surgery, and this is where they go into the spinal cord and they extract nerve rootlets and test them to see which one are causing spasticity and which ones aren't, and so they clip the ones that are primarily responsible for the spasticity. But one of the things they found out earlier, they really tried to identify using physical and occupational therapists to determine the muscle strength that the child. Initially, they weren't quite as selective, and so children who they thought were good candidates, child was using the high tone or the spasticity for stability, and when you took that stability away, the underlying strength of the muscles were very weak. So you now rendered a child who maybe was functioning with high tone and abnormal gait. But once you took that tone away, they didn't have enough power, muscle strength, in order to ambulate. So you decreased their function, and they were then in a wheelchair. Contribution to the muscle weakness is the constant lengthening that's brought on by the spasticity. If you take your arm, constant stretch on your biceps muscle. So I want you to tighten your arm as tight as you possibly can. Now try to do it in completely with your arm completely flexed, and give yourself some resistance, and then in mid ranges, and then in a completely lengthened position. Your strength will diminish as you move because of the constant contraction of the muscle to begin with. Anticipatory control is the production of the forces prior to the intended movement that are crucial to setting the posture to maintain balance upright against the force of gravity, while allowing the task to be accomplished in an efficient, coordinated manner within the environmental context. When I think about anticipatory postural control, if you've ever water skied, if you're down in the water and you're getting ready to get up on the skis, and for some reason the boat takes off before you're ready and you fall, what happens, you fall flat on your face. And because you have to stabilize your body, core, maximum stability, in order to have that force pull you up with the water ski. Well, this happens in every movement that we do. That was much more dramatic an example. But if you're sitting and you go to reach for something, or standing and you go to throw a ball, they've done studies that extensor muscles in the backs of your leg or in your trunk actually activate even before you begin the throw, because your body's anticipating that it has to maintain the stability before you have the movement. Children with CP are going to have an impairment in that. They can't maintain their postural stability in order to move efficiently. Children with cerebral palsy have what's called a poverty of movement, because they have such limitations in their movement and it requires so much effort. They do it the same way pretty much every time. So there's very little variety. If I were to ask you, you could probably come up with easily 20 different ways that you could transition from one position to the next. Coming up to standing, getting on your knees, rolling over. There's just a variety, and we all move in a variety of ways. If I asked 10 different people to come to sitting from lying down, it would be done in a variety of ways. And you yourself might do it in a variety depending on the context and the environment. But children with CP don't, because their ranges of movement are small and their movements are limited to primarily flexion and extension. Okay, so now I want you to take a look at this little guy. What are the neuromuscular and musculoskeletal issues that are contributing to his inability to move in a normal way? Okay, so this is the same little fellow we had laying on his supine. Already identified that he has hypertonicity, that he was moderately to severely involved. Child with spastic diplegia, which means his lower extremities are more involved than his upper. We already identified the extensor synergy pattern in his lower extremities, and you can see now being held in weight bearing, they now scissor. So he has that abnormal posturing of his limbs. You can see even before it was his right arm that was flexed, but you can see his hand position on the toy. The grasp is not normal, it's tightened. He's got a little bit of associated reaction in his mouth, because there is increased tone also in his face. Smiling is partially because he's happy, but part of it is the tone, that's increased tone that he has. He has stereotype movement synergies, which we talked about. Poverty of movement. He's got a very limited range of variety of movement. He has excessive co-activation of his muscles. You can see flexors and extensors are activating at the same time, which was causing the synergy pattern that he has, which is going to contribute to fatigue and decreased endurance. Can't really tell. I don't see any atrophy off. Just looking at him, his muscles are fairly pronounced. Note that the student is holding the child high on his trunk. She's doing that because he doesn't have much postural control. He can hold his head up, but even with that, his shoulders are somewhat elevated, and he's helping support his neck because he really doesn't have good postural control of his neck muscles. Children with cerebral palsy exhibit exaggerated opening of the hand during the entire movement. There's no anticipatory grasp formation. There's abnormal finger shaping and hand closing that was dependent on contact with the object. This is due because the intricate control manipulatory forces relies heavily on sensory input, and abnormalities in the sensory mechanism, such as sensory awareness and processing and interpreting that information, contributes to a loss of dexterity. You can also find children with cerebral palsy also have difficulty with dissociation movements of larger joints. For example, sometimes children who are learning to crawl, there should be a separation of the right and left hip, but the children will tend to move their legs in a bunny hopping manner to propel themselves because they have lack of dissociation in their hip joints. Okay, so let's take a look at this little girl who has cerebral palsy and think about what you've learned so far and what do you see when you look at this picture. First of all, she has spasticity, so we know that she has damage to the cortical and subcortical areas and the motor impairment. We know that she has high tone in her lower extremities by the extensor synergy pattern that she is demonstrating. Her weight is shifted posteriorly on her lower abdomen and hips, but she's got extension of her hips, her knees, and her ankles. So there's not going to be a whole lot of separation or dissociation between those hips when she goes to move. If she does propel herself forward at all, it's going to be one in a bunny hopping position where she brings both legs up into total flexion and both legs out into extension. As a result, we know that she has poverty of movement. Her movements are very stereotypical. She has excessive co-activation of her lower extremities. It's hard to really say. I think there is involvement in her upper extremities, but to a lot lesser degree, and hence the diagnosis of spastic diplegia. But we know her postural control she has lower tone. You can see that by the protruding abdomen, the hyperextension of her head, and fairly good symmetry in her upper extremities. I'm not seeing just from this picture a lot of excessive tone. The right hand is flexed where her left is extended, but I think that's probably more of a preference or a position in terms of when we took the picture. Hopefully you're beginning to see some of these things as we progress. Okay, so we've looked at neuromuscular and musculoskeletal factors that contribute to movement dysfunction, and now we're going to start looking at some of the other systems. So the first we're going to look at is sensory. We talked about this is one of the major centers of the brain was the vision, and this is many children with cerebral palsy have problems with vision. Cortical visual impairments, remember we talked about as a result of damage to the occipital lobe, It's not that children are blind visually, but they are visually impaired as a result of a processing of the brain. So you would say they have a cortical visual impairment. Strabismus is the crossing of the eyes. This is due to poor ocular motor control. Nystagmus with children with CP is a rapid oscillation of the eyes going back and forth, and you can imagine that would impact what you're able to see. Children with cerebral palsy many times do not have both eyes working together. Maybe have one eye's crossed, the other eye's kind of wandering around. This is going to impact processing, which is going to impact their movement as they're moving around their environment. One of the things that binocular vision allows for is depth perception. So if a child is even upright and moving, this could impact their ability to, their coordination as they move around their environment. Visual tracking, the ability of both eyes to work together to follow horizontal, vertical, or in a diagonal pattern. Retinopathy is the single most cited cause of blindness in prematurity. It is something that they are treating much more aggressively, but it is still noted with kids who are premature. And that's going to impact or have an impact on a child's ability to move, is how well they can see. Refractory errors are what we normally think about when we talk about visual concern. They have distant, far, or close vision. And then visual field deficits. Sometimes children may have what's called hemianopsia, homolotous hemianopsia, where part of their visual field is missing, and so they can't see something on one side. That certainly is going to impact. Many children with hearing impairments have poor vestibular function, which is going to result in balance deficit. This is less common in adults as they are already had a foundation of spatial awareness and gravitational orientation. Tactile defensiveness to touch. Too much is considered painful, and this will prevent attempts to, or they'll be under-responsive, a failure to register the touch. They forget to use their hands when motor functions are intact, but it puts the individual at risk for injury. Children with deficits in kinesthetic memory lose the knowledge of the way they move prior to the onset of the disability. This contributes to abnormal quality. There are a number of secondary impairments in children with cerebral palsy that are related to neuromuscular and the musculoskeletal systems. Joint mobility problems include those that are hypermobile and those that are hypomobile. Hypermobility is going to lead to joint laxity, and there's going to be greater range of motion than is typical. These kiddos are hypotonic. There's usually muscle weakness, and the soft tissue tends to wear and tear. The midfoot many times will break down in older children with CP. With hypomobile joints, this refers to excessive stiffness and decreased range of motion at the joints. And this is going to lead to factors that change in alignment, deformities, and pain. And many times the children will be fit with braces, such as ankle-foot orthosis, in order to try to get the best alignment with the feet as possible. There's also a number of skeletal impairments found because they typically do not walk, or if they do walk, they walk late. And as a result, one of the things that needs to happen with the acetabulum in the hip joint is the ball and socket to fit into one another. You have to have weight bearing. So even for children that I worked with around a year of age, really around 10 to 11 months of age, even if I wasn't completely sure they were going to be ambulatory, I tried to get them up in weight bearing and different pieces of equipment like standing frames to get that weight bearing, because the weight bearing helps produce the ball and socket, and prevents, when there isn't weight bearing, you have a shallow acetabulum and they are at risk for subluxation or dissociation. Femoral anteversion, kind of a bow-leggedness, if you will, when children who are allowed to W-sit, promotes a misalignment of the femur. Because of imbalances in the muscles, especially with a child hemiplegia or even bilateral hemiplegia where there's differences in the two sides, these muscle imbalances lead to scoliosis, which is curvature of the spine, lordosis, which is sway back, or kyphosis, which layman's term is hunchback. Okay, so now let's take a look at this picture and see if we can see some of the things I was just talking about in terms of secondary impairments. This little girl has low muscle tone, so her joint laxity, they have greater range of motion than normal. If you look at her trunk and her posture, you can see that as she's walking, she's probably between 2 and 2.5. See, she is trying to compensate for her lack of low tone by pulling her shoulders back and kind of hyperextending the upper part of her trunk. You can see a little bit of her scapula winging, which is also a sign of the low tone. Her shoulders are extended. Okay? And this is to give her increased stability that she's lacking. And can't really see at this angle, but she also was a little girl that had a anterior pelvic tilt. Hip flexors were beginning to get a little bit tight as a result of the lower tone. I'm not seeing any changes in her in terms of scoliosis, so she may not be having the muscle imbalances on one side more than the other. She certainly is at risk for lordosis, though, future with a combination of that anterior pelvic tilt and extension of the hyperextension of her upper back. Okay, there are a number of other systems that we look at that can have an impact on motor function, and we're going to take a look at each one of these in a little bit of detail. Okay, the first one we're going to take a look at is the respiratory system. This is a picture of a child is on a ventilator. It's going to affect his speech, his posture, and his feeding. General mobility is going to be reduced due to the poor cardiorespiratory endurance and the failure of the musculoskeletal system to develop. Decreased postural control in the upper trunk, face, and shoulder girdle is further going to complicate respiratory coordinations. Because children who are born premature have respiratory problems anyway, because the lungs are one of the last things to develop in utero, this is also going to contribute to a lack of postural control, which is decreased tone in the proximal muscles of the trunk. This leads to flaring of the rib cage, impacts the child's ability to suck, swallow, and coordinate breathing. The immobile rib cage doesn't allow for adequate breath control to support quality of speech, the loudness, the pitch, the depth, and the rhythm. So you can see this is respiratory system is significantly impacts motor control. The next system we're going to look at is perceptual and the cognitive system. Children with CP tend to be more distracted. They don't attend to tasks as long, making it more difficult to practice actions that are required for learning new movements. And infants explore the world and they discover how they can act on the world and the consequences of those actions. If the infant is limited by the amount and type of movement, they have fewer opportunities to explore their world, and then they're unable to interpret the opportunities that the environment brings. If the child has an intellectual disability or mental retardation, many times they don't have the motivation to. Children with CP have been shown to have more difficulty with self-regulation. This could be that they're in pain. It could be that the relationship between the parents and the child, maybe the parents are constantly rescuing the child because they know the child has limitations, but it's part of the neurologically just damage to the limbic system, which impacts the child's ability to self-regulate. And on top of that, if the infant's energy is consumed with regulatory issues, the the control of movement is going to be delayed. Gastrointestinal impairments also impact movement. Poor nutrition causes irritability, which causes increased spasticity. Poor nutrition decreases endurance, which impacts energy for postural control. GERD is very painful, which also is going to contribute to increasing the tone of the child, which is further going to limit the child's ability to move. So you kind of get the idea. Again, back to the low tone in the postural, in the trunk muscles, the core muscles. Many of the children have low or decreased proximal tone, so their core muscles are lower. As a result, they're going to have motility problems and significant problems with constipation. And if you've ever had these issues before, you know how just the uncomfortableness in and itself, if you had no other problems, that doesn't encourage you to move very much, even though moving might be the best thing. So it's a catch-22, because the child doesn't move as much. They have increases their constipation. Then once they're constipated and painful, then it makes it more challenging to move. Many times children with cerebral palsy will experience pain. To just kind of guess that that's what's going on, due to the fact that some of them are infants or young children and can't really tell you, don't understand. Many of them have sensory impairments, and so their perception may be off, or they may not realize that's what's going on. Children in general, sometimes you just have to guess what's going on. It's by process of elimination. If they're screaming all the time, that there's probably something going on. Pain could be for multiple reasons. It could be because of the muscle pull, that sometimes children will get spasms in their legs, spasms in their muscles. The joints are misaligned. This can cause pain. Any kind of trauma, they may be more clumsy than other children. Their immobility may cause pain. Any kind of disease or altered sensation may also impact. I worked with a young lady one time. Cerebral palsy was pretty severe. She was in a wheelchair. We had ordered her a couple new pieces of equipment. We had changed her seating system in her wheelchair, and we had also gotten her a new standing frame. It was really cold outside. She was wearing more clothing. She came into therapy one afternoon, and her mom said she was having difficulty with feet, or that they were really cold. So we took her socks off, and they were completely black. There's hardly any circulation going on whatsoever. We elevated them immediately. It was to the point I went to the ER with her, but we took her shoes and socks off and propped her legs up, and the circulation improved. And so we then started watching this, and it was happening over a period of time. And of course, she was very irritable with this. So we had to try to piece together what the changes that we had made, which impacted her alignment as a result of the equipment changes that we had made, and because of her altered sensation, her lack of mobility, all those kinds of things, it all kind of factored in together. It was extremely painful for the child. And on top of that, she also had edema. I think both things kind of went together. Not only did she have the poor circulation, the blackness of the feet, but they were also quite swollen. Motor planning problems involve multiple body systems and are evident in individuals with CP, as they attempt complex movements requiring a sense of their own position in space, the spatial and temporal characteristics of the task, motor memory, and the gestalt of the completed task. For the child to plan a coordinated sequential motor task correctly, the sensory systems must select and attend to appropriate sensory cues. So if there's sensory deficits, this complicates their motor planning abilities. Sensory input helps to organize position in space relative to objects and persons, and provides a reference of correctness as the movement proceeds. If you've ever tried going through a door and you're carrying an armload of like a laundry basket or a lot of books in your hand, you're more likely to bump your hands than you would if you didn't have anything in your hands. You can't see where your hands are. Your body image is different. And so I think it's and part of it is your motor planning abilities have not, until you've practiced it a few times, you don't have adequate motor planning. And the last part of motor planning is the cognitive system. And as we've already identified, many of these children have cognitive issues that's going to impact their ability to understand the new learning that is occurring. The impairments related to cardiopulmonary system is something that increases over time. Physical fitness includes cardiorespiratory endurance, muscle strength and endurance, flexibility and conditioning. And as we age, we all have a reduction in this. Well, I think children who have cerebral palsy, they seem to age faster in relationship to this. Their endurance gets less and less, and especially if they have less mobility. As they get bigger, they may have been, as you can see, this child maybe is about 5 or 6, but I'm guessing she's not going to be walking by the time she's 13 or 14, because there's a lot of effort in physically the caregiver putting her in and out of these contraptions, and then also for the child as she's bigger to try to move within the environment. And that lack of physical exercise, physical fitness, is going to further reduce the child's physical conditioning. Okay, so that's it for this section of looking at neuromuscular and musculoskeletal systems, as well as other systems that impact movement.